Thank you so much for being here and spending the time together to talk about one of my favorite topics. I love talking about work as a structural and social determinants of health, especially in this particular population. So, as Veronica introduced, my name is Jin Jun. I am at the Ohio State University College of Nursing. I also have a research lab called Occupations and Wellbeing. We lovingly call our lab the OWL Lab. And I will share a little bit more about what we do in our lab. But before I go further, I first would like to report that I have no conflict of interest, and any statements, interpretation, or conclusions expressed in this presentation is mine alone, and it does not reflect the positions, policies, or endorsement of the employer or our funders or even affiliated institutions. So, having said that, I have three main objectives for today's talk. First, I'd like to talk about how work is related to like health and well-being and how it functions as a determinant of health and well-being. And with that, I also would like to just kind of review and highlight the disparities and vulnerabilities that experienced by healthcare support workers. And I'll also go into who are the healthcare support workers as well. And I would like to finish this hour that we have together with some of the implications and potential social solutions that we could possibly come up with to address these structural barriers that these workers experience. So I know this is with the ERC, and um, maybe some of the contents that I will be covering may not be new to you. I think it might be a little bit of a review, but I think it is important for us to be on the same page and understand what's going on. So I would like to start today's presentation with the overview of how occupations or paid employment is linked to health and well-being. So first, there is something that more than 160 million people in this country share in common, and that number is about 80% of people that's older than 18 years of an age. So this many number of people, what we share is that we do an activity. There's some sort of activity that we do in exchange of wages. So whether, and obviously, what we do look different. So some people work part-time, other people work full-time, and it might be like a permanent job or temporary work or temp or gig type of work. But no matter what it looks like, we are working in exchange of pay. So work is something that many of us share. However, it is also something that may look different for many of us. And that's why I think work functions as a determinant of health. And for those of you that's working full time, including myself, work is the place where we spend most of our time. The only other activity that we do more than work is actually sleeping. And I don't want you to feel bad, that we're working so much because work actually is quite beneficial for many of us, especially because there are so much, resources and benefits that we gain through paid employment or our job. And those include tangible things like I just mentioned, wages, pay, but also benefits. And especially in the US, our health insurance is tied to the employment. So a lot of times that's what we gain through our employment. And also retirements, a lot of companies offer matching, or even like places like Ohio State has a pension program. And also there are some of having being able to take some time off that is paid. So those are some of the tangible resources that we gain. But there are also other things like less measurable, so intangible things, and that's reputation, credibility, skills, confidence, and sense of accomplishment. And all those things are also gained through employment. And some of the things that we don't always think about, but we feel are the social benefits and the network of relationships and connections. And some of my best friends I met through work. And also I gain mentorship and a lot of people learn like what other opportunities are and things like that. And so there's also a sense of belongings. And these are the reasons why sometimes when people retire, there may be a period when they feel lost just because they kind of like lose that sense of community. Fun fact is that 1 in 5 people also meet their life partner or their spouses at work. And myself included, actually. And about 15% of people meet at school and other places, as I listed here. So, work is something that we do, many of us do, and we gain a lot of things. So, it's not hard to imagine that what we do for living is closely tied to our health and well-being. In order to understand the health and well-being benefits of work other than the ones that I mentioned here in terms of what we gain, we have to talk about and the best way to kind of talk about it is how unemployment is linked to health and well-being. Basically, when somebody is unemployed, it's actually one of the most significant contributors to social and health inequality. So, because of just going back to that slide that I shared, because of all those things we're gaining, when you don't have access to employment or when you don't have that work and bringing the resource, it leads to the degree of inequalities that people experience. So not surprisingly, long-term unemployment is a lot more detrimental than short-term unemployment. So this is a well-known and well-researched area. Since the 60s and 70s, there are strong body of research demonstrating the health effects of unemployment. So when somebody's unemployed, it increases the rates of obesity. The cardiovascular morbidity and mortality also goes up as well. And I listed some of the research findings with the odds ratio, but as you could tell that like when you compare somebody that's working, even if they're not happy at their job, so regardless of how they feel about their work, just the sheer fact that they're employed, there's some degree of health benefit. So flip side of that is that unemployment also increases the health disparities or health adverse health effects. Also, unemployment is linked to increased consumption of tobacco and alcohol, and interestingly, it also reduces rates of physical activities. Not only this physical health and well-being, there are also mental health that's linked. I know we have a speaker coming in February that's going to talk about mental health and occupations, but here I just wanted to highlight this is one of really well done meta-analysis, and I have a citation here that was recently done that basically shows the depression and anxiety, the mental health outcomes that's linked to unemployment. So unemployed individuals have higher rates of depression and anxiety. And this is actually even true for somebody that voluntarily left. But I put a little sign here because this paper was actually done during COVID. So during COVID, they looked at people that voluntarily left their jobs. Even though it was their choice, the fact that they were unemployed was linked to higher rates of depression. So there's this some sort of like psychological scarring as the longer your unemployment goes on. The good news or interesting fact is that when a person gets re-employed, so once they find a job, then there's definitely some degree of a reduction in depression and anxiety. But whenever a person experiences episodes of unemployment, there is some sort of a psychological scarring that's happening. So we know that work has a strong relationship to physical and mental health. So there's another concept that is considered or that's called underemployment. We know a little bit less about underemployment versus unemployment. Unemployment is that you don't have a work for pay. Underemployment is when you are employed, but you are employed in a job that does not fully use one's skills, education, or experience, and or you are working fewer hours than you want. So sometimes you want to work full-time hours, but your company or your firm does not have the position, so you end up working like 20 hours a week. So that's considered as an underemployment. So what we know about underemployment is similar as unemployment. There's definitely association with adverse health effects or health outcomes. So when you lose a job, so that is unemployment, but also decreased work hours, that's more than the number. So when you have work hours are decreasing, then the number of days that you feel unhealthy in your emotional and mental health goes up. And another thing about is that when you move from the secure employment, so when you knew your job security was stable, going into even underemployment or unemployment without benefits, then your mental health also declines as well. In this study, this is not, that's my first name, but this was a different author. In this study, what they found is that when somebody became unemployed, but they received the unemployment benefits, then that mental health effect was a little bit buffered. The other two concepts, so job insecurity is actually quite tied to that underemployment because you are underemployed below your skills and education, or your hours are more reduced or limited. So there's a sense of job insecurity. So a person may not feel like they have this secure job. So this sense of job insecurity is also linked to increased or worsening heart disease or risk for heart disease. And what we are seeing is that job insecurity is more closely linked, or you see more of the somatic symptoms. So I have a little picture here. So worrying about the job situation, and sometimes you have like, stomach, gas, GI signs and symptoms. And those like somatic symptoms are linked to job insecurity, whereas unemployment is more associated with depression and anxiety. So there is this really interesting report. It's actually out of UK, early 2000. So as I think I hope I'm making a case demonstrating that work is, closely linked with our health. And when you don't have the paid work or underemployed, there are all these like negative health outcomes. So then the ultimate question is work good for your health and well-being? So that it was somebody that's really smart and brilliant wrote a report. And this is a really, I love this paper. It's one of my favorite papers. If you have time, I encourage you to read it. So in this, what they're finding is that re-employment, as I mentioned, like once you lose your job and then you gain that employment again in different position or something like that, re-employment will reduce symptoms of like, depression and anxiety or other distress. And so that's been found in multiple different studies. But another thing is that because your work is linked to so many of the resources and benefits that we need in life, when you actually change jobs, you could enhance your socioeconomic status and also opportunities may increase. So like, the shifting and moving jobs and having jobs will create these enhanced socioeconomic status. And also, so what we are seeing is that employment supports better mental health well-being. And but I want to highlight here the caveat here is that usually that better mental well-being is notable when it's paired with good quality work and good supervisors and favorable work conditions. So what we're concluding based on what I just said is that job is good for you, but it kind of has to be the right job for the right person and right position. And I think that's the key. So here, I don't know, I've been talking for about like, I think 15 minutes or so. So some of you maybe out there are probably thinking, sure, this sounds all fine and dandy. It's very academic. You're talking about all these like benefits and da 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 da. But many of us have to work because we have bills to pay. So we might be at work. I don't know where you are today, but you might be at your desk, or maybe you're thinking about your work and internally you're screaming. So here, I think I need to just pivot a little bit and acknowledge and do a little review or like overview of the occupational stress, because I think that is important. And we've been talking a lot about this in the last decade or so. So, you know, these like public survey after survey always ask like what are the most the biggest stressor in life. Oftentimes people say work related things, and this one was published I think in 2023. And but regardless when this survey was done, like what are the biggest stressor in your life, it's the Stress Institute and NPR and a whole bunch of different organizations do this every couple of years. And usually money and work are the two things that come up. But money and work are tied together because work is the main source of income for many of us. And so usually what's causing work stress? And oftentimes it's related to the alignment. So I mentioned in a couple slides in the back, work is good, but it has to be in the right place, right job for the right person. So work stress is also caused by like role conflict. So like underemployment is a good example of this. Sometimes the role ambiguity. So like I'm sure you've been in jobs, I have, that you're like, oh, I don't really know what I'm supposed to do here. Like those are the kind of thing. And responsibilities, workload, and the person and organizational fit. So not just me and what I want, but like the fit between the employer or the organization and what I want. So there's like organizational politics that play a role. So it's supervisors and managers and all those things, and relationships others. So when you have and there are some concept of burnout contagion I've looked at in the past during my postdoc years. Kind of like one of the predictors for a nurse's burnout is actually other nurses' degree of burnout. So like when you work with people that constantly say that they're burnt out, you are more likely to feel your burnout. So all these things are causes for work stress. And I think this is kind of like repetition a little bit, but this is another reason why underemployment is a factor in a lot of adverse mental and physical health. So this is just like a quick overview. I teach pathophysiology at The Ohio State, so I always have to include this picture about how stress is linked to all organs of your body. There are many different ways that people exhibit signs and symptoms of stress. So, and just kind of like talking about that picture that I just had on the previous and more in the context is that work stress has been linked to cardiovascular disease. And I don't know if you ever seen this picture, but working long hours and, there have been some videos about workers in Japan working long hours and they just kind of pass out and things like that. So there are more and more empirical data that's showing that like, we need a break, and these like chronic long like job strain and work hours are detrimental to our health. But I want to highlight this because work stress increases cardiovascular risk by about 20%, but that risk goes up even higher for people that are in low wage, high risk jobs. So, and that comes in play when I start to talk about more about the health support workers. Not only these are cardiovascular risks that people experience related to job stress and job hours, but also it affects sleep. And I think at least a lot of people that I know, and including myself, have lost sleep over my job. There's been work stress and things. So mental health, I talked about this already, but it's also affecting sleep quality and quantity. And about 76% of people said that my work stress affects the amount and quality of sleep. And another interesting thing is that work stress also affects relationships. And that is called a spillover effect. So workplace stress causes or can cause problems at home and also lead to family conflict because you bring stress from work to home. And I bring this up because sometimes we say that we should leave work at home, work at work, but sometimes because you feel stressed and you are being affected, you can't just close that brain. And there are a lot of anecdotal, like personal stories of like I left, my job stress at job and at home I'm home. But I think that's something that everyone is different. It's not, one is right or wrong. But I showed you that picture of the body, and I bring that up because it's demonstrating that when you feel stress, it affects the whole body and there's a mind-body connection. So there is negative work-family spillover, and not surprisingly, that is linked to greater number of chronic illness, greater functional limitations, and worse self-rated health, even like 10 to 20 years later. So when you have it may feel like acute like work stress, but if it's prolonged, it could have this like spillover effect into the personal lives, but also that could lead to the long-term effects. Here's some interesting like a model to demonstrate like how work stress influences like the outcomes, but the way this team modeled this is that when there is like work demands, it's gonna have this like a family conflict, and that's gonna create stress and lead to further conflict and then lead to like worse outcomes. This is another interesting little stat about that 87% of people in this report, they surveyed about like 4,000 adults, I think. And then they asked, do you think that how you feel at work, does it affect you at home? And about 80% of people said yes. And another thing that, I think more and more people are talking about is that there are discrimination and racism that experienced at work. There was a paper by Commonwealth, it was a report actually that came out in 2024, and that said about 50% of healthcare workers have seen racial discrimination that's happening in their facility. And of that, population of that healthcare group, 60% of Black healthcare workers and 40% of Latino or Asian Pacific Islander workers have personally experienced discrimination at work. And that report was with the healthcare workers, but even in other industries, this does happen. And a lot of workers of color report that they fear retaliation for reporting discrimination. So a couple of years ago, I did a study. It was a study with Asian Pacific Islander nurses, and we examine, we asked them, like, do you experience race-related harassment at work? And we looked at its association with racism or discrimination at work linked to work outcome. So burnout was our outcome. And this is our finding. What we found in that study is that when a nurse reports more than few times a year race-based discrimination, then they were 2.67 times more likely to report burnout. So uh, sorry, I went too fast over there. But so unfortunately, work is something that almost all of us do. Like about 80% of adults are involved in some sort of work. There are a lot of benefits and resources we gain, but it's the same coin. It's on the other side. So the flip side is that it is also a place where we experience negative health effects, discrimination and other negative experiences. So I hope I'm convincing you up to this point that like, work is closely tied to people's lives. So with that, I want to talk a little bit about health disparities. So people who are earning low wages, often every paper defines that slightly differently, but on average about like less than $20 an hour. So that's considered as low wage. So occupations earning low wages have been associated with increase in mortality. And that paper, I believe was published in JAMA, and that looked at low wage lifetime low earning wages. So somebody that's in low wage jobs for much longer are at a higher risk for early death or increase in mortality. And low wage earning jobs are also associated with faster cognitive decline, and as I mentioned, obesity and cardiovascular disease and hypertension are also associated with low wage jobs as well. And because low wage jobs are oftentimes more physical and at more like less ideal working conditions, so they might be outside more or they might have to climb trees or something like that. So low wage earning positions are also linked to high rates of physical injuries, just the sheer conditions and exposure that they experience. And as I mentioned, depression and anxiety and mental health are linked to low wage jobs. So I want to pivot here a little bit and talk about healthcare support workers. So, and there are different terminologies that we describe healthcare workers. So who are healthcare support workers? And this is a healthcare workforce group that provides support care in various healthcare settings. So they work in nursing homes, home health, and even hospitals and offices, like many different settings. And these include all. This list is not This is not comprehensive. This is like just like examples, and there are other titles that I may have missed, but sometimes we refer this group, the healthcare support worker group, as a direct care workers. There's an organization, PHI is a nonprofit organization that focuses on direct care workers. So PHI kind of talks about the similar population. They use the terminology direct care workers. I use the term for this presentation, healthcare support workers, because that is the term that Bureau of Labor Statistics use to categorize all these jobs. A lot of people don't realize that the healthcare support worker group is the fastest growing occupational group in healthcare, mostly because we need them always, but also our population, the general population, is growing older. So there are higher needs for the support workers. And because this is a very diverse group, when you combine all these workers together under that umbrella term of healthcare support workers, it is actually the largest healthcare group of 6.7 million. So it is much bigger than nurses. And that number includes unlicensed personnel, like and home health aides and things like that as well. And if we're just looking at nursing assistants, they are about 1.4 million. Um, so why do I study healthcare support workers, or why should we study why are we focusing on them today and beyond? Is because healthcare support workers are working population that are both users, so they use healthcare, but at the same time they're stores of healthcare because they really are the group of people that touch the patients most directly. They are at the bedside more than anyone else. So because of their duality and because of their directness, they are positioned at this intersection of social and occupational hierarchy, gender, race, and socioeconomic status due to their role and also the pay and all the status that comes with it. So healthcare, the interplay between their job roles or job titles and the wider socioeconomic context contribute to that persistent and systemic inequality in the workforce. And as I mentioned, it is a large group. It's about 6.4 million total. They earn about $17 an hour. Just for the context, if we were to just look at all workers, the national median wage, like just crudely averaging it out, is about $23 an hour. And for the, and there, I'm sorry, $28 an hour. And when we think about hourly wage in terms of like livable wages, that's about $23 an hour for Columbus, Ohio, where I'm located. And I think it's about $28 in California. So when you think about the hourly rate in the context of livable wages, they are a lot lower than what is considered as livable wages. Another thing about healthcare support workers is that mostly women. About 89% are women. It is overrepresented by people of color, especially women of color. It's 64% of the, if we're just looking at the women, then it's 64% women of color. If we combine men and women, it's about 56% people of color. And this group is also overrepresented by immigrants. About quarter of the healthcare support workers are immigrants. And the health of healthcare support workers, I spent a lot of time in the beginning of my presentation talking about the link between work and health. So I don't think this is a surprise. So healthcare support workers earning low wages, doing a lot of physical direct care jobs, they also have when they are compared to clinicians and the public, they have higher rates of respiratory illness, higher rates of cancer, and other chronic illnesses. This is a figure from a report that's published by the Center for Health Workforce Studies. This came out in 2024, and here and you can't, I don't think you could see these, I will tell you. The blue is the healthcare support workers, and this that light blue is a therapist. So they basically categorize them by support workers, LPNs, registered nurses, physicians, therapists, and others. And here we see that the support workers have high rates of all comorbidities combined, and mental health, the LPNs were higher, but for the most part, the support workers experience higher rates of other illnesses compared to higher earning um, provider groups. And my team and I did analysis using a national health interview survey. It's publicly available data. A couple years ago in 2023, we pulled the data from NHIS survey from this, and we basically were interested in like what is the difference between job types. So we compare the healthcare support workers, nurses, and other clinicians, and what are their health behaviors looking like, and do they use preventive care services? Our thought at the time was that even though health insurance is closely tied to employment, not every nursing assistant or not every direct care workers are actually able to obtain health insurance. That's a whole nother that I might talk about it a little bit more, but what we are finding is that I have another study that I will show you that shows it, but because of their job conditions and the employer type, so a lot of the healthcare support workers, even if they are working full time, they may not be eligible or they do not get benefits like insurance through their employer. So that's why we were interested in looking at the preventive care service utilization rate and health behaviors of healthcare support workers. So in this analysis, what we find was that healthcare support workers had higher rates of anxiety compared to clinicians and general public. And compared to clinicians, they were less likely to receive preventive care and they were less likely to receive flu vaccines, but they were more likely to get preventive care and more likely to get flu vaccine compared to general public. So this finding told us basically what we concluded from this analysis was that what I said earlier about the healthcare support workers being at the intersection of the healthcare user and the store. So they may have a different characteristics than the general public, but they also have different characteristics in terms of health and health behavior compared to other healthcare professionals. And we did another study, so we were like, okay, then healthcare support workers and other low-wage healthcare workers compared to clinicians, like, what do they look like? Or, like, do they get enough insurance? Like, are they eligible? So this is a different study. We did a primary data collection with this. We sent out a survey using a registry research registry called American Population Panel, and that is run at the through the Department of it's Arts and Science, the College of Arts and Science. We have a survey research center that have a research participant registry called APP, American Population Panel. And we send out a survey asking the healthcare workers, like, do you receive medical insurance? Do you get vision, dental, and flexible spending? Do you have PTO? All those things. And what we found, and for this particular study, we also included service workers, healthcare service workers, like the environmental services, transporters. So what we are finding is that the service workers and support workers are less likely to receive. They all get insurance, but at lower rate, but they also receive lower rates of flexible health spending or paid time off. And similar to what we did on the previous study, we also looked at preventive care utilization. Like, are there differences? What's their behavior looking? And we found that the blood pressure, cholesterol, all those chronic cardiovascular health related preventive care services, the service workers and support workers were a lot less likely to receive those. So we are seeing the disparities even among the healthcare group. So by depending on the job categories, they had different degree of access to the benefits. So this got us really interested in social determinants of health, and we wanted to know more about, like, what about food and housing, all those things. There was a study done by another team a couple years ago looking at social determinants of health of healthcare workers. And in all honesty, if you were to ever like do a PubMed search or Google Scholar search trying to find any information, like what, because healthcare workers are asking patients about patients' social determinants of health. But there's actually very, very, very few studies examining the social determinants of health among healthcare workers. So this study was one of the few that looked at all healthcare workers and asked all the employees in this healthcare system about, do you have food insecurity, financial strains, and all these things. And they included physicians, nurses, healthcare support workers. So in this descriptive study, what they found is that about 38% of nursing assistants or the clinical support, and these are the healthcare support workers, and 38% had food insecurity, 32% had financial strains, and 25% said they are unable to pay for their housing. Compared to that, the patients reported 17% of the patients had food insecurity compared to 38% of the support workers. For all employees, on average, within this, it was a one healthcare system, about 11% had food insecurity. So this is just kind of showing that this is a employee working group that's experiencing a lot of instability in their social needs. Um, This was also shown into the PHI. I did a shout out to PHI. They have a report. They actually also found that about 36% of the direct care workers have lack of affordable housing, and close to 50% rely on public assistance like Medicaid and nutrition, and 36% live close to poverty. So we have a current study. Unfortunately, we're not quite done yet to share the results, but I will share just like a quick glimpse of the study that we're doing with a hospital-based nursing assistant. And even in our study, this is a preliminary finding, is that 54% of hospital-based nursing assistants that we surveyed reported that they are experiencing some degree of food instability. This is not quite food insecurity, but they just are not able to meet their needs as often as they could. And 58% said they couldn't always afford to eat the balanced meal. In the same study, we asked about housing, and about 42% said that they are very worried or always stressed about how they're going to pay for housing. We are in the process of collecting qualitative data at this time. Some of the participants have told us that they had to basically bargain with their landlord, just like pay half of the rent, like right now, and then pay the other half like 2 weeks later because they are so paycheck to paycheck. So, so these are all the reasons why I conceptualize and I kind of try to understand the role of work as a structural determinant of health. And what I mean by is that I'm sure you've seen some sort of a picture like this. More now we are saying that 40% of your health is due to the socioeconomic factors. I wouldn't get too hung up on the numbers just because I went down the rabbit hole and these numbers are just kind of like it evolved. It's not as definitive as this, but we do know that social and economic factors play a big role in people's health. And this is like an older model. It's the kind of like the founder, or I don't know, it's like the beginning of the social determinants of health model. So in this rainbow, this this group basically started to looking at these like working and living condition as the basis of how people's like health and well-being are like formed. So it's not individual's choice or individual's decisions, rather it's the around the context. So this is kind of like what we were thinking, and obviously all the data that I shared you about the food insecurity and housing and all those things, they fit under here. But because all these living conditions, like paying for housing, that requires earning some degree of money, right? So you need to make enough money to pay for housing. It just wasn't quite capturing the whole downstream effect of work and wages and benefits and working condition and all those things. And I think a lot of other people were sharing my thoughts because I think this was from 2024 or 2020. I can't remember exactly what year this figure that HRSA had a presentation, and they actually said we need to look at structural, the like upstream factors that actually impact the social determinants of health. And those structural determinants are the governing process, the policies, and the economic and racism, discrimination, and the segregation, and all those things have that downstream effect that impact all those social determinants of health, and that leads to it. So these are all the I think many researchers and many people are now talking about this. So the way I envision and conceptualize this in relation to work is this figure. So I developed this figure just for me to think about this more clearly, is that structural determinants of health, by definition, is economic, cultural, political, social structures that shape the distribution of material and symbolic power and resources. And because these things are the upstream factors, then they basically influence social determinants of health, which are the circumstances in which people are born, grow up, live, work, and age. And what we measure, so food insecurity, housing insecurity, underemployment, unemployment, all those things are then experiences of social determinants of health. To me, I think it's important to like understand or like distinguish these upstream and downstream relationships and factors, because sometimes we because this has implication in terms of how we envision the problems and the solutions and how we dream about the future we want to create. So I want to make an argument. Just like so, I want to present an example of why this figure makes sense in terms of when we talk about work. Is that so? A lot of us know that there's a differential opportunity. So one in four employed women in the United States actually work in what we consider women's work. And that includes like teaching young children, cleaning services, and providing care and such and such. And the thing about this type of work is that they tend to pay lower compared to other work. So they also have fewer benefits. So like all those like resources that I mentioned. And these are overrepresented by women of color. And even in that quote unquote low wage women's work, there is a gender difference in their pay. So they found that even in like the cleaning, the janitor work, for every dollar a man makes, a woman was getting paid about 86 cents. So there is some gender difference. And this is not individual's choice. A woman did not choose to get a job that's 86, that pays, 14 cents less than a job. This is some sort of a structure or the policy, or so that is kind of like an example that I'm using. And there was a report that came out in 2024 that kind of basically did a simulation calculation with the gender wage differences. So if we were to collectively put all that together, then basically there's about like $42 billion of wage that's like lost or that's not being paid or that's not being distributed because of that segregation. Similarly, there are differences in job opportunities by geographical location, so rural versus urban. There are a lot less job and quality jobs in rural areas. So that also is not, you could always argue that a person could move because it's not that simple. So these are not something an individual chooses, but there's like something beyond that. And these two examples that I bring up are important because what I have not talked about as of yet is the intergenerational effect. So what your parents do, what you do will or can have an impact on our children's future as well. So when we compare different countries, they did find that there is a higher inequality and lower intergenerational mobility in the US compared to other advanced high-income countries. And what they are finding is that parental income was a predictor for adult children's earnings. So there is some degree of intergenerational effect. And when they kind of like calculated this out in economic model, what they saw was this J curve, meaning this parental income affecting children's earning potential is really strong at the top. So high earning parents really can push their children to even get higher or better paying jobs than they could. But there's at the same time, the lower income family also had strong predictors. So the strongest was the highest, but the lower group also had a very strong relationship. So hopefully, I'm not making you feel this way, but sometimes because I spend every day of my life thinking and studying these things, I feel like this. But I don't want us to leave this discussion feeling despair because I think there's a lot that we could do. So let's just change some directions and talk about implications and future directions. The thing is that people expect a lot from, I should rephrase that. People expect and want and believe that our workplace can do. Like it is a thing that we should benefit from. So a lot of people, so close to 90%, so 87% of people agree that work provides more than paycheck and they can provide more paycheck. And they also feel important that they find a place of an employment that care about how they feel. And they believe, people really do believe that it's possible for people to be happy at work most of times. And I do too. And there is a generational differences. So Gen Zs expect them more from work compared to the baby boomer. So all the things that I discussed so far are what we call wicked problem. And wicked problems are they have characteristics, and the main characteristics are it's very hard to find a consensus and agreement, and they tend to persist over time. It's these are wicked problems are they're very uncertain, and it's quite ambiguous. There's a high degree of ambiguity. There's no universal, clear-cut solution. There's a lot of interchangeable, overlapping variables that are at play. So it's wiki problems are very ambiguous, complex issues. And for me, when I think about these, all the things that I talked about up to this point in this frame, it helps me to kind of think about what can we do? Because wicked problems the thing about wicked problem is that we have to accept that there's no singular solution exists. This is not a problem that we're going to be able to solve with technology, with one thing or like, one policy or one big policy to change. These are persistent. It existed before I was even born. It will exist even when I'm gone. So for me, I take comfort in that. And also it gives me hope because it's a problem and we just keep tinker at it. Like we keep at it. I maybe I'm not convincing you that we could do something about it. I hope that I do after, the next 10 slides or something. So this book, this was the one of the books that this phrase, the wicked problems and righteous solution came from. And that book was actually about computer programming. But with this book, and there's been many papers published since then about how do we use social solutions to address wicked problems. And the first step is to accept that there's no single solution and acknowledge the complexity. So it is what it is, and we're gonna just keep trying because we can make a difference. And the second thing is the more action-driven aspect is that we need to do a data-driven um, iterative process. So it's map the problem, what's the problem, and then develop solutions or portfolio of solutions and try it, fail quick, and do it like just over and over again. And also bring people in. There's like a share ownership. I'm studying workers, and it always has to be the population at the center. And continuous communication, collaboration, and acknowledging to each other that we may fail, but the beauty is in trying. And so with that, I wanna just kind of like come because it's a huge wicked problem, I want to take a small portion out of it and just kind of like share my thoughts on like maybe these are the areas that we could talk about. So I talked about intergenerational mobility, but it's also occupational mobility. So what we are finding is that including healthcare support workers and other jobs, and especially in other low-wage jobs, that switching jobs is actually good because every time you switch jobs, you could find another job that pay better. So switching jobs can improve wages, but it doesn't always mean that you have the occupational hierarchy, upward mobility. And what we are also finding is that there was a study with like a bigger data set. What we're finding is that for nurses of color, when they change jobs, they actually basically what the second bullet is saying is that for people of color, when they change jobs, they don't like lose. There's not a whole lot that they're gonna lose. So it's okay for them to every time they change jobs, they were able to increase the wages. And I have another study that I just completed. It's under review, so I can't share the graph on the presentation. But what we are finding is that healthcare support workers, including nursing aides, they do a lot of them constantly change jobs and they move up. And but when we take out like moving into nursing, like other jobs or higher positions, it's a lot lower. So what we are seeing is that the healthcare support workers and other people in low wage jobs, they are always looking for, there's a lot of high mobility with jobs. So then the conclusion I'm drawing from that is that job changes, not staying in the same position, can offer an opportunity for wage improvement. So, what are some of the areas in that we could help? Or what are some of the programming that we have available that could actually kind of address this issue? So I'm not offering any solution per se today, but because it's a wicked problem, I wanted to present as like a small chunks that we could do. The thing about wicked problems is that incremental changes are okay. And I think that's the big lesson that I'm taking from this line of work is that the way I'm presenting this occupational mobility is that like this is a one area, but if we could come up with some righteous solution in assisting for people that want to change or move up or do something different. So it's kind of like thinking about the social issues. So this is kind of like summarizing that changing employers, so changing jobs can lead up to increased earning. And the thing about, so kind of like thinking about the solution is like, can we think about like then agencies? I know like, there's also pros and cons about agencies but if changing jobs can improve wages, is there a way that we could leverage that to kind of boost up this population and create more opportunities? Another topic that I kind of think about is retirement. So people similar to that changing jobs, when especially people who are older, when they change their jobs in their 50s, like so later in life, so they do something and then they change their jobs in their 50s, they actually stay in workforce longer. And we could talk about like, is that good or bad? But aside that, what we are seeing is that they do stay in workforce longer. But the issue or the challenge with the healthcare support workers is that because their jobs are so physical, they really cannot I mean, some people do stay longer. There's always this, bell curve. But for the most part, I'm talking about the people in the middle. They do leave workforce a little earlier than the typical retirement age. So then linking that occupational mobility that I just shared, can we then come up with something for voluntary job mobility for healthcare support worker to move into so that they could stay in workforce longer? This graph over here, what we're seeing is that I don't think this is a surprise at all. This was published by Vanguard a couple months ago, and people who max out in their the 401k contribution are the ones that's a high earning workers. So when we think about healthcare support workers or other low wage earning workers, they fall under this category right here. So they really don't have a lot of retirement saved up or they cannot contribute max to to what they want to contribute. So then we help, keeping them in workforce until they are eligible for Medicare and things like that can actually help them a little bit. And I kind of like, I wanted to just, you know, kind of start to wrap up this presentation, kind of going back to more of this like social and structural determinants of health. And I love this diagram that published by CDC. So this is kind of like a how they propose that we address these determinants or drivers of health. And through data and surveillance, a lot of research and evaluation things, we do that. And but also community engagement and partnership. And lastly, policy, infrastructure, and law and things like that. And I want to just highlight some of the policy things related to healthcare support workers, but they may have implication. And when I say policy, I want to just say that like I'm not saying like everybody needs to like run for an office or anything like that, but it is important if this is something that we're interested in. If someone like me who thinks about work as a structural determinant of health, then it's always interesting to see what are current policies emerging because it will have an impact. These are not short-term impacts. We cannot see the differences right away, but it is important to understand and know what's going on. So, and policies happen at many different levels. And this is a beautiful city of Santa Fe. I don't know if anybody's here from New Mexico, Santa Fe, but recently Santa Fe was the first city to basically link their minimum wage to local housing cost. There's a caveat because they are capping it at 5% per year increase so that employers are not drowning. So this will basically will increase their minimum wage, I believe, to 17.50 by 2026. Right now it's $15 an hour minimum wage, and they're increasing like little by little. But ultimately, their goal is that their minimum wage will be kind of like linked to the housing costs, so that way people can make a livable wages. They estimate that this will help about like 9,000 workers. So honestly, the even at the federal or local level, the minimum wage a lot of people do make slightly above minimum wage, but it's really the most vulnerable workers will benefit from this. But beyond that, it will be really interesting to keep an eye on this policy as we continue to see the inflation and the cost of living goes up at much faster rate than our wages. So policies like this are coming up. A lot of different cities are talking about it now too. So this is a policy to keep an eye on. The city ordinance just passed, like, I think October 2025. So this is very new. At the state level, many of you are, or at least at this ERC is in California, and California passed this SB 525 in 2024. And that basically said that healthcare workers have to get paid minimum, and there's a table of like time and when this will be applied. And so basically they are proposing that minimum wage for healthcare workers will be at least about $24. This is actually quite complicated because they have a different minimum wage for like different settings, like hospital versus nursing homes. But the gist of it is that the minimum wage will increase to at least $23 to $24 an hour for healthcare workers. And this will impact about 400,000 healthcare workers. And Berkeley put out a report about like calculating how much this is going to cost, because the biggest cost for employers is labor cost, and they estimate it to be about $2.7 billion that's going to cost to the employer. But the idea is that there will be savings related to turnover and things. So this is a state policy and thing that just passed that's interesting to keeping on. I definitely know I'll be following this. At the federal level, there were a couple different bills, but there are two acts that were proposed. They both basically repealed or didn't pass. The first recently, the federal policy mandate on the healthcare support, like the healthcare worker minimum ratio in nursing homes. It was required under the Biden administration, but it was repealed December last year. So the nursing homes do not have to follow this anymore. But I present this as a wicked problem. So wicked problems, the solutions are not gonna happen like right away, but the beauty or the effort is in trying and doing it. The second one is the Long-Term Care Workforce Support Act. This actually did not pass in 2024, but under this act, they were proposing a wage increase in healthcare support workers. So whenever on like a policy or bill like this gets introduced and they don't pass, it's not the end of it. We revise and redo it, and so I don't know. I'm always finding energy behind the act rather than the outcome. I don't know if I know we get tired, but I think I really find strength in the collective effort. So I'm almost done with this presentation. Kind of like as a researcher, I have to also highlight that there are also many different like research and practice implications. I think we need more causal evidence using quasi designs. And and the longitudinal, also all the policies that I just introduced, we need to start thinking about like, the natural experiment, like let's see what happens and keep checking in and like that, try quick and fail quick and doing it over and over again. And also the interaction between these multiple labor policies, even the Santa Fe, the minimum wage, the city ordinance, that doesn't exist in its vacuum. So like how does that look like under, something else that's happening, and downstream effects of like just how people have access to healthcare, how healthcare workers can actually get healthcare if they don't get a lot of benefits like I share in our data. And also mental health is a big piece. Lastly, translate that research, so what we know, into actionable guide to the policymakers. We have to work together, and that actionable guide could look like a policy brief. It could just be a phone call to the office. So I think these are some of the things that what I think of as like, the righteous solution for our wicked problems. So I want to finish this presentation with just introduction and just kind of sharing um, our lab. So in our research lab, we have a vision. Our mission statement is that we want to be a part of the solution in creating a world where every working person can build a life of purpose, prosperity, and possibility for themselves and their families. And this is not to say that non-working person is not important or less deserving. This is a mission statement for our lab, which focuses on occupation. And we do this because there are many different ways. And even in my presentation, I talked a lot about different things. And these are some of the research areas that we're focusing and we're building on. And so I just wanted to say that. And I do not do this work alone. I have an amazing team of students, collaborators, mentors, and research coordinator that I always draw strength from. So I want to just highlight that. And I just want to finish this presentation by introducing a current project that we are starting and we're recruiting. And this is called we are calling this the PATH study, title Positive Approaches to Thriving Through Occupational Mobility. We are recruiting Black African American women leaders in C-suite, so people that are in like CNO or CEO positions that are 50 years or older who began their careers in direct care positions. The purpose of the study is to understand and really gain from their lived experience how they navigated their successful career. We want to learn from their strength and their power. And the study is funded through the Michigan Center for Urban African American Aging. So we're recruiting. Here's a QR code for our screening survey. If you know anybody, please do share. And we have a couple other current and past projects, but they are all listed on our website if you're ever interested. So to wrap it up, the three key takeaway is that work is good for you if you make it work for, if work is good for you if you make it work for you. And it's not enough to just talk about social determinants of health. We also must address the underlying social and structural determinants. Lastly, wicked problems are daunting and but they need, and we don't have to solve it right now. I think it's frustrating at times, but with adaptive, ethical, and collaborative solutions, and we embrace incremental progress and we can make the world just 1% better. So that is my takeaway. Thank you so much. And we just want to honor and thank all the workers, especially healthcare direct care workers. We see you, we value you, and we thank you. So thank you so much for your patience. That was a very long presentation. So I will stop talking right there.
That was excellent. Thank you so much, Dr. Dunn. I think we all got a lot out of that presentation. And again, we will be sharing the slides and this talk, it was recorded, so we will be sharing that too. We do have a question in the Q&A feature if you want to go ahead and look at it there. I'm going to read it out loud. It says, thank you for this wonderful and informative presentation. I find that many nurses are hesitant to discuss structural, socio-political context for why social drivers or determinants of health exist. I think there's a sense that talking about structural issues automatically makes your work biased or controversial. However, we live in a time of soaring social inequality and, frankly, state-sanctioned racial profiling, thinking here of ICE raids on workplaces, which certainly have major health implications for workers and communities. Moreover, I think it's the American Nurses Association Code of Ethics explicitly states that nurses should be advocates. How do you balance this tension in your work?
Oh my God, that I don't know who asked that question, but like my heart, like I hear that, I feel that question. I talked a lot about different topics. I could only speak for myself and, my team and I talk about this sometimes. And I think first is that I want to just say that the sense of safety is number one. So that, all of us work in different settings. So it also is a context matter. And if your workplace does not feel safe, then I think the rest of it, I think so that needs to be maintained. And assuming there is a sense of safety, then it's not about, I think this is something that I think about often. It's not about like which side of the party but as long as we center, for me it's about centering, how do we keep our workers, like healthcare support workers, healthy and well. So like kind of anchoring with that, and I always go back to the evidence, like, so I try to be always rooted in the empirical evidence and also like center that purpose. I don't know if that made any sense, but it's like, so for nurses, it's the patient's safety and what the patients need. So less of me and what I think, but it's more like what is needed and what is important for the purpose and the goal and the people, the population that we're serving. Then it always for me takes out the my own worries and just, but then that's always within safe space. So if your workplace is not safe for you to stand up, then I think that's different, but assuming that safety is there.
Thank you so much. And if anybody has any other questions or a follow-up question to that, we'll go ahead and just give it a couple seconds here to see if we see anything in the Q&A feature or in the chat. As we wait, I actually have a question. As you were
Sure.
talking about all of the different factors that healthcare support workers face, whether it's underemployment or all the stress, it made me think of, all the people that are possibly shying away from going into this field, right?
Uh,
So, or all of the different types of jobs, in this, on all of the different positions or roles that you had mentioned that encompass the healthcare support workers. Are there any programs that you know of that are kind of encouraging? I know you mentioned like legislation that was trying to, I'm sure,
yeah.
lift the wages and everything to make more people go into this field. But are there any kind of programs kind of encouraging this? That you know of? It just seems like because of the aging population, we do really need workers.
Mm-hmm.
But
Yeah.
yeah.
That's a really good question. Thank you for asking that. So, so worker recruitment and retention into the workforce is a big challenge. It's always been something that we've been thinking and working on. And every conversation, not that I had many, but the few conversations I've had with like lawmakers, that is something that they care deeply and it comes up time after time. And that is kind of like nonpartisan issue. Like it doesn't matter which side or what you believe. We all agree that we need more qualified workers. And so and to answer your question in terms of programs, there's actually a lot of state and organizational, state, city level programs. And one of my mentors actually also had a high school, how the students in high school program to like basically introduce them early in like, I think freshman high school to start introducing them to the healthcare support role and then kind of like but using that as a bridge to for like something else whatever they want to go into in the future but using this role as like a bridge like introductory and even in Columbus one of the high schools have a program like that. Like if you choose, like if the high school student chooses the healthcare track, then they work with the medical center or something like that so that they could like start not so much as like working. It's not like a, exploitation of free labor. It's more like high school students to experience and be exposed. Along with that, it's not so much about recruitment, but like there are some efforts in like also trying to standardize like the training and how people are like become piece like the nursing assistants. So there are things like that. And also Maryland also has another policy with it's like direct, I forget what it was called. It's like Direct Care Act or something like that. So it's about training. And so there, to answer your question, there are a lot of movement happening in that space to bring people in. Not only that, keep people where like, so it's not this position, that role does not always have to be just like fly fly zone. You know what I mean? It's like it could just people don't always have to like leave if they because some of the nursing assistants that we're talking to right now for our study, they are so proud of what they do. They highly value what they do. They believe in their work. So there are people that want to stay. So it's about recruitment, but also retention.
Yeah, and I see in the chat, somebody wrote supply and demand. Seems like there's a structural problem and an oversupply of low skill folks that end up in healthcare support jobs. I don't know if you want to comment about that.
Um, the strict oversupply of, hmm, I'm not sure. I'm not sure if we ever had oversupply of low, just because the turnover rate is so fast. It might, I don't know how to answer that question because I don't know if it's an issue of oversupply. It's more of an issue of volatility. So it's people come in, they leave. So I really wish that I had that paper published so I could share, but we basically created a graph to see like where people move, like changing jobs with the healthcare support workers, and they were like up and down, like they were in and out, in and out. So it was constantly essentially that if it was a revolving door, it was constantly turning. So if I don't know any place that's been oversupply, but it is a structural issue of inability to keep them. And because once again, labor cost is the biggest cost in every industry and every, and so.
And we do have one more question in the Q&A from Marianne Rosenberg.
Oh.
Thank you for such a compelling talk, Dr. Jun. What do you think we can do to promote the workers' voices and their sense of control? Unfortunately,
Mm.
structural determinants of health is out of their control, but what can be done at the individual level while we try to tackle those bigger wicked problems?
I honestly, I push back a little bit that it is not within their control. So when I say structural and when I present policy, I am a little worried because I am presenting it as if like, the discussions are happening like over somewhere like at the state capitol, but workers have voices. I think the first step is acknowledging and owning the voices. Because it's all humans, like no one human is above the other. And there are, so the structural things, it's like, collective voice is the voice. So I think that is where I would start with. And um, so I'm trying to think if there's anything else I could add to that. But I think that's what comes to my mind. So when I say structural, I don't necessarily mean that like the worker individually have to go and change the policy because we cannot do that. But there's like local policy is also structural, like within the institution, within the unit. Like so kind of thinking about the span of control, like from where we are and then like what can I do? So and I really try to make it with the wicked problem as like it's not something that is like hopeless. It's because it's wicked and it's because like so persistent. Any little thing we do, even 1% better is better than it nothing. So I feel like I may not have done the best job at trying to convey that hopeful message today, but um yeah.